All righty. Hi, everyone. We're at the 7 p.m. mark. So I would like to welcome you all to this evening's webinar on transitioning from pediatric to adult inflammatory bowel disease. My name is Kelsey Shane. I am the Executive Director at the Canadian Digestive Health Foundation, and we are thrilled to welcome you to this evening's webinar. So this webinar was made possible due to an unrestricted educational grant from Pfizer Canada. So thank you, Pfizer. And just wanted to give a little bit of a background on CDHF, the Canadian Digestive Health Foundation. If you haven't checked our website out, I definitely encourage you to do so. We are the trusted source of digestive health information. We're committed to providing useful, up-to-date information and research to help Canadians better manage their digestive conditions and live healthier lives. So just a few housekeeping items before we get started. If you do have any questions for the speakers, we will be answering them at the end of the presentation. So just make sure that you submit your questions in the question box on the bottom of your screen, not in the chat. And if you have any questions specifically for one of our speakers, just please include their name. Recording of this presentation will be available on CDHF.ca afterwards to review on a later date. So definitely be sure to check out the website or our newsletter for that. So without further ado, I would like to introduce our wonderful speakers this evening. We have Dr. Cynthia Seow. She is the Professor of Medicine, Division of Gastroenterology and Hepatology at the Departments of Medicine and Community Health Sciences at the University of Calgary. We also have Dr. Jennifer deBruyn, who is the Associate Professor, Section of Pediatric Gastroenterology at the Cummings School of Medicine, University of Calgary, and Alberta Children's Hospital. And I'll pass it along to you.
Thank you very much, the CDHF and all the audience that's online. Again, thank you for this opportunity to present today. And I'm really pleased to be able to do this with my pediatric counterpart, Dr. deBruyn. So I'm an adult gastroenterologist and Dr. deBruyn's a pediatric gastroenterologist, and we do welcome any questions during this presentation. I'm going to be taking over control of the screen now. And if it all works, these are our objectives tonight. We wanted to discuss how to optimally transition a patient from pediatric to adult IBD care. So our objectives tonight was to describe the process and the importance of transition and to really focus on what the difference is between transitioning somebody rather than just transferring them from one center to another. We wanted to distinguish the needs of the adolescent with IBD and the needs of the caregiver, because a caregiver is so important in this process, and to familiarize adolescents, their families, and providers with tools and resources to enable a successful transition. Just trying to figure out this control. So I wanted to give you an example. This is a 15-year-old, and I haven't actually stated, we've got a picture of a guy here, but it could be a guy or a girl, but this is just a representative case history for you of an individual who's developed Crohn's disease at age 8 years, undergoes surgery at age 12 years, and receives infliximab at a community infusion center. And this individual takes methotrexate, folic acid, and vitamin D, and comes in with his or her mum to the pediatric GI clinic. And Dr. deBruyn would be familiar with this. If the patient is going to be turning 18 in 3 years' time, how do we best get this individual ready to enter the world of adult GI? Does the age matter? Does the disease matter? What kind of things do we need to prepare this individual for? And does it really matter if this is a guy or a girl in terms of medications, the whole transition process? So I'd like you to keep that in mind. So I'll pass over to Dr. deBruyn here.
Thanks so much, Dr. Seow. So next slide. So the concept of transition is thankfully now gained much traction in healthcare. And we are very fortunate to have a well-established definition of what transition should incorporate. And so transition is the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from a child-centered healthcare system into an adult-centered healthcare system. Some of the principles of transition planning is that it should begin at an early age. So in our case scenario, we had it at 15 years old, but I'm going to show you some of the things that we do even into early adolescence in order to start preparing our teenagers. And in addition, the transition planning should be a gradual process where we focus on building independence over time. One of the very important components about transition for us is that it is a set of skills and knowledge that are happening in not only the clinic and hospital setting, but it's also happening at home. And many of these skills that our adolescents are acquiring are reflective of both what they need in the healthcare system as well as what they need in general life. And the last component of transition is that it addresses the multiple complex needs of an adolescent and their family. And it's looking at the medical, psychosocial, educational, and vocational needs during this process. Next slide. In contrast to transition, we have the concept of transfer. Sorry, the next slide.
Sorry, Jen, there's a bit of a lag with things because I'm controlling Kelsey's slides. So it tends to go about 30 seconds after.
Okay, no worries. In contrast, we have transfer. And is it the same or is it different from transition? Well, transfer is really a one-time event as opposed to this process of transition. And transfer is that one-time event when we make the care, the movement of care from the pediatric side to the adult side. And this is jurisdiction specific. In most places, it is typically around 18 years of age. And then in certain jurisdictions, there may be exemptions and such, but in general, it is a set age that, that the clinics are following.
So when we talk about a conceptual model of transition, we're obviously changing from child-centered care to adult-oriented care. And as Jen mentioned, this is not a one-time transfer process. We start this process really early on because, as you can see on the left-hand side of the slide, a child-centered care is generally a nurturant type of style. We make decisions along with the kid, but obviously parents are very heavily involved. And one of the big focuses is on growth and development and, of course, disease control. But as you well know, with inflammatory bowel disease, if it is not well controlled, then the child won't grow well. So that's really important. And because they're entering into an organizational care, we do standard intervals for face-to-face encounters. But as you can see, as time moves on, we transition them across the way until they're finally transferred into the adult center. During this time, it is so important that the parents as well as the individual knows more and more about their disease. This means that they know what their disease is, when they were diagnosed, what their medications are, and also what their goals of care are. And we'll be talking a bit more about treat to target, so where we want patients' symptoms to be well controlled. And I always say that symptoms reflect quality of life, but there are other ways that we need to monitor them. So we need to monitor in terms of doing blood work to look for adverse effects. We look at sometimes stool fecal calprotectins, which we find really helpful as a non-invasive marker of disease activity because it can predict a flare. Then we can sometimes use radiologic or sonographic measures, as well as the endoscopy, which is something that worries a lot of the children. But we want to sort of encourage kids as well as their parents to know the importance of the endoscopy, because we know that if we can control a individual's disease well and bring that colon under good control and heal it, then the risk of having flares, needing hospitalization or surgery decreases. So that's all part of the knowledge place. And as time goes on, the individual learns how to manage the disease well. And this is the hard part, balancing the child's autonomy versus the parent. We know the parent is so important in this process, but as time goes on, we're talking to the individual themselves. Parents are always welcome, but we focus a little bit on different goals here. And the patient is given that autonomy to contact the clinic whenever they're worried about things. We still have some standard intervals for assessments, but we ask the patients to reach out and let us know when they need to be seen. Back to you, Jen.
Sounds good. So an important concept when we are working through the process of transition is to look at goal setting. And we set goals for our teens. And we also, and Dr. Seow also has goals for her young adults as she meets them. And we also do see that these goals change over time. So I'm going to share with you this next slide. So some of the important components that we discuss about with our adolescents is that we want them to develop health literacy, self-advocacy, self-management, and self-efficacy. So what do some of these concepts mean? When we talk about health literacy, we want our adolescents to be able to know their condition, know their medications, and to really know their story. Sometimes we find that for our teens who have been diagnosed a long time ago, they may not have been aware of all the nuances of what went on in the early years. And therefore, it is important to bring them up to speed on that, so that they can then share their story and be confident in knowing their story when they meet any new healthcare providers along their way. Next concept is building self-management. And so a lot of this focuses on what our adolescents and young adults are able to do for themselves. Can they take their medications as they're prescribed? Do they know how to manage their symptoms? Do they know how to manage their stress? And what do they do when they are having problems with their symptoms? Who do they call? And what do they do about it? And in that sense, that's helping them learn to be advocates for themselves. The other important part for our teens is becoming involved in decision making. And we really try to involve the teens in becoming a shared decision maker. And for most of their lives, their parents have been their primary decision makers. So this is really a big step for them to become involved, to know their options, and then have a say in it. And along that lines is advocating for themselves. And I talked about that earlier, knowing what to do in an instance, knowing how to get the information that they need. And then lastly is self-efficacy. So this is a really important part of what we try to instill in our teens, is that sense that they have the skills and they can be confident that they can be successful in their transition of care to adult GI world. So as I had mentioned earlier, some of these concepts actually start quite early. And even though our case scenario, our patient was 15 years old, many of these things we do even at an earlier visits in order to build this process of independence. So when they are in their early teenage years, I like to start seeing them alone for part of their visit. Obviously, I recognize that when I then bring in their parents, usually the parents are anxious and waiting outside the door. I don't think they're listening in through the door, but they're sitting down the hallway. And when I bring in the parent in, the parent is usually very relieved to be a part of that part of the rest of the discussion. But it is important because I think that The teens need to recognize the importance that they are being seen alone, that they have the questions asked directly to them, that they provide an answer to me, and that separation from the parents is really valuable. And it also helps, I think, release a bit of that parental grip that was shown nicely on that other slide, which is understandably a very, one of the big important concepts of transition is that separation from their parent. At that early age, we have an age-appropriate discussion of meds, tests, treatments, and we also have the teens start to know their meds, start to know the names of them, and maybe even familiarize themselves with the dosing and things like that, just so that they can develop their own health literacy. As they gain further into the adolescent years, more of the visit is spent by seeing the teen alone. Again, we have them meet with our multidisciplinary team. This might include our social worker, our pharmacist, our nurse and dietitian. We try to give them strategies that will help them become more independent in taking their medications and tracking their healthcare appointments. We also want to help them better understand their health history and why they are on the meds that they are, what side effects they need to watch for, why we do the tests that we do, and why is it important to monitor. And then the last important part about a transition that for families is drug coverage. So we start discussing that in their mid-teens, but it especially becomes a very important part of focus when they are getting near to that age of 18, when oftentimes there is a very distinct age of separation for drug coverage for them. Next slide. So when we look at some of the needs of the adolescents, we do recognize that this is a time when they are exploring their schooling, they're exploring their education, they may be undergoing physical body changes. And so it is important to incorporate all of these components when we are thinking about the needs of the adolescent. The needs of the adolescent can also differ. Sometimes we have teens that are very stable in their disease state, and that can make the transition process much smoother. But when they are having a lot of active disease and we're going through medication changes, we need to recognize that that can be another contributing factor that we need to account for when we're doing this transition process. And so the teen who is having multiple medication changes or unstable disease or even new onset disease, that all needs to be taken into account when we discuss the needs of the adolescent. We also know that adolescents are at risk for mental health and psychosocial issues. So those are also assessed and addressed, and it includes evaluating for anxiety, depression, social isolation, and altered self-image. During this period of time, there may be shifts in their housing and in their personal circumstances. So we also like to discuss that. And we also want to reiterate the importance of coming to clinic, the importance of medications, the importance of monitoring, and all of this for their disease control. Next slide. For our parents, it is a process in and of itself. And so we often have our social worker and our pharmacists meet individually with the parents too. I think it's especially important for our social workers because for the parents, they have been so involved in their child's care for the past 18 years, regardless of whether it's been related to IBD or not. And so this concept of needing to release independence can be challenging. And I think some of the steps that we take to alleviate this fear or concerns is by doing it through a stepwise process, and also by allowing the teen to demonstrate their independence to their parent too. And I often like to tease our teens that part of this is looking after their mom or dad in the process, and making sure that their mom or dad is well looked after during this time. But it's something that I know that even as they get into the adult world, it isn't such a cut and dry line for the parents, and that transition process, just like for the teen, it can come after they turn 18. This transition process for the parent can be a longitudinal factor as well. Next slide.
Oh, there's a bit of a lag here. Okay, let me get back to this. So what do we expect in the adult versus the pediatric GI world? So in the same way that Dr. deBruyn teases her teens that they have to look after the parents, I tease them that much of the focus on the first appointment is about sex, drugs, and rock and roll. And they often looked a little bit perturbed and a little bit shocked by it. But I told them, you know, we've usually had such a wonderfully written transition or transfer letter from the pediatric world that we already know a lot about their disease, where they're at, and at the first appointment, a lot of the focus is really on telling them, what do we expect in the adult world? And so the reason I break it down to this kind of little euphemism is it helps the teen realize what's important to me and what's important to them. And ultimately, I tell them that their disease should not define them. So when I meet them, you know, I would say, you know, tell me a bit about yourself. And I do get concerned if they say, you know, I'm 18 years old, you know, I've got adolescent Crohn's disease, I've had it for 15 years. I said, like, okay, stop for a moment. Tell me a bit about yourself. What do you like to do? Are you in school? What do you know, what's going on in your life? So when we break it down this way, I tell them, like, let's start about sex or relationships. But really what I really want them to tell me is, you know, do they have friendships? Do they go out? Are they having relationships? Or on the flip side, can they, you know, go out and play a basketball game? Or are they worried about having an accident on the basketball field? Or basketball court? Are they worried when they go to the movies that they won't be able to watch the whole movie and they're going to step out? And therefore, are they not playing sport? Are they not able to go to the mall to go shopping? Are they not able to go to the movies? And so when I talk about this whole sex thing, I want them to reassure me that they have friends, that they know how to socialize, and they're doing what most teens will do. So I ask them that question every time they come, and I tell them I don't need all the other specifics, but as time goes on, the teen will no longer be a teen, but a young adult, and we will later be talking about things like preconception counseling, what is the effect of their medications on their body image, on their sexuality, things like steroids, as you know, make people put on weight, give them acne, you know, it makes them worried. And again, that impacts on their self-image. And patients are worried as well about whether they'll be able to have a family of their own in the future. So obviously this is not all covered in the first visit, but it sets the stage for it. And by asking these 3 questions about sex, drugs, and rock and roll each time, it normalizes it for the patient. So when I move on to the second topic of drugs, I say to them, you know, I want to hear, what do you think of the drugs that I've put you on? Meaning whether that is their mesalazine or their Mezavant, their azathioprine or Imuran, or their biologics. Do they think it works? Are they worried about being on these drugs? Are they worried about the side effects? And that's a good discussion to have, because as Dr. deBruyn said, patients need to be, you know, have an understanding of what are these drugs, what do they do, and what are the goals for the treatment. And as we discussed before, it's treat to target. Ultimately, we want their symptoms, we want all their blood tests, we want their poop tests, we want their ultrasounds, and we want their scopes to be normal, because if they can demonstrate that healing, then again, they're much less likely to require steroids, needing to come into hospital, and needing surgery. I also ask them about drugs. What other things are you using? And are those drugs complementary, meaning are they looking at naturopathic medications, vitamins, minerals, acupuncture, any of those kind of things, and including cannabis use? And are they using it as a complementary medication? And if so, why? That's okay with me, but is it because you feel that your pain is not well controlled, or do you feel that your energy is low and you're feeling fatigued? Is that why you're taking them? Or on the flip side, are you taking these as alternative medications? And that always concerns me, because if they're taking something that's alternative, meaning that they're not using our medications, then we really have to ask why. Again, do you not think that the medications that we've prescribed work? Are you worried about the adverse effects? And so are these complementary or alternative therapies? And then it sort of segues into the discussion of, are you using alcohol? Are you using are you smoking? Are you vaping? Are you using cannabis? Or are you using any other forms of drugs in inverted commas? And what are they? And again, why are you using them? And very importantly, the third topic is rock and roll, which I say is, what's your vocation? Again, your disease doesn't define you. What is it that you want to achieve in life? How can we help you with that? Is this post-secondary schooling that you want to do? Are you able to concentrate when you're listening to lectures? Are you able to sit your exams? Why have you asked for accommodations? Is this because your disease hasn't been under control and you're rushing to the toilet during lectures or exams? Or are there other things that are contributing to it that is not just related to your disease activity? Is there anxiety and depression that's making you, giving you trouble concentrating? Because we need to discuss that. Or if it's not studying that you want to do at the moment, that's okay. What work are you doing? What job are you doing? How are you coping with that job? And are you able to complete a shift? Are you able to get to those goals that you want to do? Are you able to rise through the ranks if that's what you want to do? Or what is stopping you from doing it? So that's kind of why I always bring up this kind of loose narrative of sex, drugs, and rock and roll, so that each and every time we make sure that these teens are achieving what they want to in life. And we know that their goals will change. And so it's very important to have that open discussion. The second topic is common. Often the teens will come in and say, mum or dad is having a much harder time with all of this than I am. They wanted to come into my appointment. Then they're outside there. Do you think you'll be able to talk to them afterwards? And as Dr. deBruyn said, I usually prefer to speak to the teen first by themselves and then bring mum and dad in later, and then we recap everything. Or we do it the other way, that I bring the parent in first, we have a good discussion, and I'll say, can I have a little bit of alone time with the individual? And, we may delve a little bit deeper into sex, drugs, and rock and roll, because some teens will not want to talk to their parents about that, or they're embarrassed, or they're not used to discussing things like cannabis use, contraception, and other things. So I think it's important that we have that separation. I tell my parents, the parents, that they're always welcome to attend the appointment or part of the appointment. But when it comes to calling the clinic, that should be done by the teen or the individual. They have to make their own appointments. They have to tell us what their symptoms are, and they have to be there for the appointment, because it does happen that sometimes we have an appointment and the caregiver or the parent turns up without the individual reporting the individual symptoms. We need to see the individual because they are the patient. And that's about devolving responsibility from the parent to the individual. And often the individuals are really keen to talk in the consultation, but sometimes the parents get the better of them. So it is important for us to separate that out. It's not because we want to break the trust between the parent and the child or the teen. It's because we need to delve in a little bit further and to establish that relationship long term. The third common area that we get asked about all the time is, will I be awake for all my procedures? I hear that when I come across the adult hospital, that we don't get put under and that we're going to be awake, and that's really horrible. And that is the biggest myth that we like to bust. That is not true. We do colonoscopies and endoscopies, as we mentioned earlier, because our goal is to see that the mucosa or the lining of the bowel has healed, so that the patient doesn't have complications of their disease. And I know I've said that multiple times, but that is our treat to target. That is our eventual goal. If they achieve that goal, we're all reassured by it. And there are other non-invasive ways for us to reflect on disease activity. And that's why we do blood tests, why we ask for stool specimens. And when we do these procedures, it is true that at the Children's Hospital, kids often get a general anesthetic because when they're little, they can't follow all the commands. They don't really know what's going on, and it can be a traumatic experience otherwise. When they get to the adult world, we do use conscious sedation, meaning that we do give them medications to help them forget the procedure, to deal with the pain, but it's not a general anesthetic because we think it's important for the individual to be able to let us know whether they're having discomfort, to be able to talk to them a little bit during the procedure. And very importantly, most of these teams are bigger than I am. I can't flip them or get them to turn or follow commands. So we do give conscious sedation. The majority of patients will not remember the procedure, but it is a different form of sedation, but we are not there to torture them. And we really, really emphasize the role of using endoscopy as a goal of our therapy, again, to prevent complications. So from a practical standpoint, these are top questions. Who will remind me to take medications? You're the patient, you're the individual. You should be reminding yourself to take your medications, and we are happy to help with reminders. If a patient is on oral medications, they are expected to go to the pharmacy to fill those prescriptions. If they are on injectables or infusions, we do have biologic coordinators as well as pharmacists can help with that. But the primary responsibility is with the individual. Who is going to pay for the medications? Dr. deBruyn already mentioned about insurance copay. Patients should be aware of whether they are covered by their parents' insurance. Fortunately, for most individuals, they have their parents' coverage till 18, or if they enter post-secondary education up to age 21. I always reassure my patients, you will not be expected to pay for biologics and other treatments, but you do need to fill in the appropriate paperwork. Compassionate coverage is to ensure that nobody is suffering financial hardship, but the companies are not so compassionate when the forms aren't filled in. So you need to fill in the forms. The compassion is for making sure that you're not having to pay up for the medications, but you do need to fill those forms in. Similarly, who's booking the appointments? At the end of our appointments, we will get you in contact with our booking clerk, with our nurse. It's for the individual to book that appointment themselves. And whilst parents can be online at the same time for phone calls, we do encourage our patients that they are the ones that have to call. Mum and dad can be on speakerphone, but the questions will be directed to the individual, and it's for the individual to report symptoms, not mum and dad saying, can you please follow up with my kid, because they are too scared to call. We should be able to establish that rapport, and that is why we have so many people in the clinic, including booking clerks, nurses, counselors. So there's multiple ways that they can get in touch with the clinic. Dr. deBruyn will soon cover the tools and resources that are available to patients beyond what we've already discussed. And very importantly, what happens if an individual is moving out of home, moving out of province to work, to study? The good news is that there is a national network for pediatric as well as adult IBD physicians who are interested in this cohort of patients. So we usually know our colleagues across the country. We have many, for example, that will be, for example, studying in Quebec, but then they come back for their appointments at Christmas time, summertime, things like that. They always have an emergency contact in the province that they are studying in case things go wrong, but they can always call us and we will still be their home site. So it's important for the individual to say, please remind me, who do I contact when I'm in my studying province? Can I come back and see you in between? Who do I contact in terms of my biologic coordinator? Do I have a pharmacist over there? It should go both ways. But there will be the primary gastroenterologist is usually in their primary province, but we do help with all that coordination. Very importantly, don't forget your family doctor. This is so important. Family doctors are an unparalleled resource. They are trained to deal with any and all health problems, and they do provide an excellent first point of contact along with the clinic nurses and clinic staff. And really the importance is to focus on wellness, physical, mental health concerns, and they treat the whole person. So we work very closely with the family doctors, and it is important for all individuals to have a family doctor for all the other medical problems. We are there as their primary GI person, but they should have a family doctor because the family doctor will also help with continuity of care, a long-term relationship. While patients move from pediatric to adult care, as we mentioned, things like family planning come up. Yes, there are IBD preconception and pregnancy clinics. There are IBD clinics in the future that, specialize more in senior issues, but the family doctor is there at every stage of the game and are also excellent at referring to other specialities if there are problems that are not directly related to the inflammatory bowel disease and require regular review.
So now to speak a bit more about what tools and resources there are available. We have transition readiness questionnaires. There have now been several developed. Some are specific to IBD. Some are applicable across all health conditions. And these can be readily used in the clinic and can be administered to the teen, the parent, as well as the healthcare team. And it provides a very good point of time assessment of where a teen sits on the transition readiness. And I feel that it can be an eye opener. We administer this about 7 times today in my clinic, and oftentimes there is a discrepancy between what the teen feels that they are confident with and what the parent feels that their teen is confident with. So it also provides not only a good assessment of where each party stands, but it also helps us to be able to identify where there are areas where the teen may feel good, but the parent may not feel confident about, and helps us to try to focus on these things. And even, for example, like one of the items is on having a family doctor and having a relationship with that. So the transition readiness questionnaires talk about a lot of these points about health literacy, about self-management, and gives a good reflection for both the teen and the parent on where they stand and on what sort of things they need to work on over the next few years. Having a multidisciplinary team is very important, and we are fortunate in the pediatric world in that we have resources of social workers, pharmacists, nurse, dietitians, as well as the pediatric gastroenterologists to provide a tailored approach to each teen and to their family. We recognize that the needs are complex and the needs are unique to each individual. And so therefore we can spend that time assessing and then providing education and providing recommendations as well as strategies for how to foster independence. I think that if anyone is going through this process, it is important to always ask and see what services are available at your center, and be able to reach out to your healthcare team to see if there are opportunities to chat with different allied health staff. There are numerous smartphone applications that are out there now that can be helpful for our teens to be able to track their symptoms, their diet, their mood, their medications that they use. And this can all help to improve their knowledge of their IBD and improve their self-management skills. And then lastly is the concept of a transition navigator. And this concept has been gaining increasing recognition across centers and across the world. What a transition navigator is a person who can support the teen or young adult through this transition process. And so it is a person who works directly with that teen and can tailor tailor the program to what this teen needs. And they can do multiple things, such as helping the teen know how to navigate the healthcare system, and even sometimes going with them as they navigate their healthcare system. So this might be, for example, like how to arrange for blood tests, or how to know how to call my doctor, and what do I say when I call, or the nurse, and what are the things that I need to say on the phone when I talk to them. The transition navigator can also be useful for helping our teens and young adults in finding resources that may not be related to healthcare. So they can help with looking at issues of housing, finance, transportation, and such. This person is also available, importantly, not only during the time when the person is under pediatric care, but is also there after the transfers of care to adult GI happens. And that can also be a time when there may not necessarily be the social worker, pharmacist, or dietitian available, but this person can help to determine how to access these resources if need be, or if these were tasks that the transition navigator were comfortable with providing input on, they could help to provide some insight on how to gain knowledge into these issues. The transition navigator program is being evaluated through Crohn's and Colitis Canada in a formal studied fashion, and it's our hope that we will be able to have a position like this available across Canada for our teens and young adults with IBD. I know that across centers, for example, in Alberta, we had a large transition navigator study, and the goal is also to be able to implement transition navigators at our children's hospitals in Alberta. So it doesn't have to be somebody who's necessarily specific to the world of GI or IBD, but it can be somebody who is equipped with the skills to help guide this transition process. Back to you.
Thanks. So with all of what Dr. deBruyn and I've said, I thought we would recap with our case study. Fast forward to this individual. As I said, it might be a guy, might be a girl who's now 18 years old. And to remind you, this individual developed Crohn's disease at age 8 years and underwent surgery at age 12 years, is receiving infliximab, takes oral methotrexate, folic acid, and vitamin D, and comes in for the first appointment at the adult IBD clinic. So again, our pediatric colleagues are really kind to us. They usually make sure that the patient's disease is well under control before we see them for this first appointment. And, but don't fret. If an individual is unwell around the age of 17 years, there is a lot of dialogue between pediatric and adult care to ensure that if a patient is sick, that we have a good plan going forward. It doesn't come as a surprise to us. We know what the major issues are for that individual. We make sure that we transfer the file across. If in this case, the patient's on infliximab, we get a biologic coordinator involved. If an individual requires imaging or endoscopy, all of that is well written out by the pediatric team to us so that we know when we need to do those things, and the patients are already expecting that to happen. So there are no surprises. As we discussed before, if you look at the mantra of kind of sex, drugs, and rock and roll, if this patient is well controlled at present, again, are they having friendships, relationships? Are they planning on going to school elsewhere? How can we facilitate that? When we look at the drugs, do they know where they're going to go for their infusions? Are they okay with the methotrexate? Is it making them nauseated? Is that why they're taking the cannabis, to try and get rid of nausea? Then that's something that we have to address. Or if the patient's on methotrexate and is a female, is this a young individual who is sexually active? What do we need to talk about in terms of contraception? We mentioned here about vitamin D, because with any of our patients, preventive care is so important. And we've already touched on here the role of nutrition, meaning what are they eating, but also external things like their vitamin D, their vitamin B12 stores, their iron stores. All of this are things that we think about in the background because nutrition is important. Vaccination status is important. We always look at that. And we look at cancer screening as time goes on, maybe not at age 18, but that's an important area for adults. And then most importantly, as we said, mental health. So for all of our patients, we do discuss disease activity. We do the sex, drug, and rock and roll discussion, but in the back of our mind, we always are thinking about preventive care and are constantly reviewing vaccinations, nutrition, cancer screening, and mental health. So it's a really big discussion. As I said, not everything will be discussed necessarily on the first visit because we don't want to overwhelm an individual, but that is why we always make sure that there is a close follow-up and there is a checklist between pediatrics and adults to ensure that all is covered. So with that, hopefully that gives a little bit of information about what we're expecting when a patient is being transferred, and I'll let Dr. deBruyn conclude our presentation.
Sounds good. Thank you. So I hope that by the end of this presentation, you will have appreciated that transition is a process. It is purposeful, it is planned, and it is tailored to the needs of our adolescents and their families. And what tips do we have for our teens and young adults? Start the process early. It's never too early. And it's really important to learn about your health. Learn about your medications, learn about your medical condition, and take responsibility for your health in the process. Be engaged, ask questions, and make decisions. And very importantly, look after your parent or your caregiver during this process. It's sometimes not easy for them during this time, and you probably are always still their baby, as I like to call it. We had lots of those discussions today in my clinic with many of my teens who their parents were still very attached to and probably will always be attached to. But in this process, we just want you to gain independence and to gain the skills that you need to look after yourself and be confident and comfortable in that. And then it's so important to remember that your disease doesn't define you. And Dr. Seow very nicely put it earlier as well. And what I always tell my teens is that I know that IBD has been a large part of their life, but it isn't all of them. And I do know that having IBD has brought them to the point where they are today. And in so many of them, I see an incredible sense of compassion, resilience, as well as gratitude in how they approach life. And so I do acknowledge for sure the journey that our teens have been on, and remind them that it isn't all of them, it is a part of them, but they are so much more than their IBD. And I do commend them that they can be proud of how they've journeyed through this as they make this transition process from the pediatric world to the adult GI world. And with that, we would like to conclude, and we thank you very much for listening in and watching in on our presentation.
Thank you guys. Thank you both so much for that very informative presentation. That was really, really great. And thank you for taking the time to do that tonight. We do have a couple of questions that we'll get to, and I'll just start firing them off and you guys can answer them live. So first, can you give a refresher of which resources highlight why the need for folic acid and vitamin D in addition to methotrexate?
Sure. So for the folic acid, in all of our patients who are on methotrexate, we supplement with folic acid because of how methotrexate affects the metabolism of folic acid. So that's just something that I always say is paired together. If a person starts on methotrexate, they are always supplemented with folic acid, one of our B vitamins. The vitamin D is not specific to methotrexate, but it's something that we use as one of our nutritional recommendations for all of our patients. I think if you live in Canada, essentially you'll be vitamin D deficient. Especially during the winter months. We do check our vitamin D levels on our children as part of our regular nutritional monitoring. And it's part of, it's not uncommon to encounter vitamin D deficiency. And we know it is important for the bones as well as the immune system functioning. So it is why we have vitamin D as part of our nutritional, preventative and health maintenance plan.
Perfect. That's great. And another question came in. Do you have any advice for taking a regular probiotic if on Mesavan daily?
That's a pretty specific question. The role of probiotics, I think we actually, Dr. Maitri Raman and I will be covering diet and IBD in the future, in the new year. So you can tune in for that one. Generally, the data has demonstrated probiotics only really having a role in patients who have an ileoanal pouch where they've had reconstructive surgery. I am very aware that many patients like to take probiotics, but in the general scheme of IBD, they haven't been shown to be effective as a lone therapy. Patients can use it as an adjunct, but not as an alternative medication.
Perfect. That's great. Next question, are there groups or workshops or virtual like this for teens to listen to, and where to find a dietitian to support a teen with ulcerative colitis?
Sure, I can address the dietitian part. I think that if a teen is being followed at one of our bigger tertiary care centers across Canada, so like in the big cities like at BC Children's or ACH here in Calgary, or Stollery Children's Hospital in Edmonton. So there's all those equivalents all spread across Canada. So if your teen is being followed by a pediatric gastroenterologist, I would ask that pediatric gastroenterologist for a connection with a dietitian. I think that I can't say for absolute certain, but the vast majority of pediatric gastroenterologists would have dietitians as part of their clinic. So I think that you can certainly ask your GI clinic about how to get access to a dietitian. And then if there's not access to a dietitian right within the clinic, you could also ask your GI doctor about name and contacts of a community-based dietitian. And sometimes these might be covered by a person's healthcare plan. And so it may be looked after that way, but trying to talk with your GI doctor about finding somebody who has some expertise in inflammatory bowel disease and comfort with discussing it is a great way to have a point of contact to find further resources. In terms of groups or workshops, I think that several centers, we had more of these types of sessions prior to COVID. And one of the really hard parts about COVID was that it made it difficult for us to meet in person. And during that time, the healthcare system was stretched quite a bit. And so I know that even for Dr. Seow and myself, like, it is one of the things that we are wanting to put back together is having transition talks or events for our teens so that they can gain this information. I think that the best place to ask would be to ask your GI doctor about where to get information on if anything is going on locally. Crohn's and Colitis Canada also has some resources on their website, but I don't think that at this point in time there's anything that is a workshop or virtual that's there right now. But you can explore through that site, through that website as well. But I think that asking your GI clinic is probably the best place to find resources that are local.
Mhm.
And I think that I saw the comment above also about social worker. I know that social worker is also site dependent. Some GI clinics have social workers, and some GI clinics may not necessarily have that resource just for their clinic. So again, I would, if you have concerns, I would talk to your GI doctor, and sometimes even if they may not have a social worker specific for that clinic, they may have a hospital social worker who could help to identify, help with some of these issues, and help you facilitate getting a connection.
Mhm.
Perfect. That's great. And I'll answer the last question there. It says, will you run more information sessions like this? Yes, as Dr. Seow mentioned, we will be having some other webinars upcoming in the new year. So definitely check out CDHF.ca to stay updated on all of our webinars. But I think that concludes the presentation. I want to thank you both again for taking the time to do this tonight, and have a great evening, everyone.
Thank you very much for the opportunity to present. And again, please feel free to reach out to your pediatric as well as adult GI. We're not scary. We're happy to answer questions, and we do have a lot of resources. Again, it's dependent on your site, but we always have resources either in-house or connections out of house to be able to help you out. You are not alone in this journey, and just remember that your disease doesn't define you. We're here to help. Thanks so much to CDHF and Kelsey.
Thank you so much, guys. Have a great night.
Thank you so much for joining.
Bye.
Thank you.